Welcome to PRISM Rounds, the audio journal club where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, physicians, trainees, nurses, pharmacists, and respiratory therapists. A quick note before we start, this episode is created using AI-generated voices. I originally made these episodes to support my own learning and review, and I'm sharing them publicly in case they're helpful to other busy clinicians and learners. Because the voices are synthetic, you may occasionally hear mispronunciations of medical terms, drug names, or author names. Thanks in advance for your patience. Everything you'll hear is for education only and not medical advice. Let's get into today's paper.
Imagine standing at the bedside at 2 a.m.
Oh, I know that feeling well.
Right. The monitor is just blaring, cutting through the quiet hum of the intensive care unit.
Yeah, that alarm just gets into your bones.
Exactly. And the arterial line tracing on the monitor looks, incredibly soft.
Barely a wave at all.
Right. You've pushed the norepinephrine up. You're basically pouring alpha adrenergic agonists into your patient, and the mean arterial pressure is still just sliding right into the floor.
It is genuinely one of the most terrifying, helpless feelings you can experience as a clinician.
It really is. The body has simply stopped listening to you. The peripheral vessels are completely vasoplegic, and your go-to catecholamines are just hitting a physiological brick wall.
Yeah, it's the defining nightmare of critical care. You're standing there, watching the microcirculation fail in real time, knowing that with every passing minute of profound hypotension, the end organs are suffocating.
You know you need a different key to unlock vascular tone because the primary lock is completely jammed.
Perfectly said.
You are listening to PRISM Rounds, a podcast for trainees and practicing clinicians in pulmonary, critical care, and sleep medicine. We break down important papers, translate the evidence to the bedside, and keep it practical, supportive, and fun.
So glad to be here for this one.
Today, we are taking a deep dive into the exact moment the medical community realized we needed that second physiological key.
Right. This is a huge one.
It is. We are unpacking the landmark February 2008 publication in the New England Journal of Medicine titled Vasopressin versus Norepinephrine Infusion in Patients with Septic Shock, the trial we all refer to as VASST.
VASST, it changed everything.
And alongside it, we are analyzing the brilliant accompanying editorial by Dr. Joseph Perillo.
I mean, this is a foundational piece of literature. If you are managing critically ill patients today, the algorithms you follow, the order sets you click, they all come from this.
Yeah, the mental models you use to resuscitate a patient in shock are all heavily dictated by the aftershocks of VAST. So let's start with the clinical why. Because to appreciate a paper from 2008, you have to sort of transport yourself back to what the intensive care unit looked and felt like at that time.
Oh, it was the Wild West in some ways.
We had these patients in severe refractory septic shock, and they were routinely just maxing out on norepinephrine.
Yeah, the prevailing strategy was often just to keep turning the dial up on the catecholamines.
Right, until you either achieved a blood pressure or the patient succumbed to the toxicity of the drugs themselves.
Which is awful. And the problem with that historical approach is that it ignores the underlying cellular reality of profound septic shock.
What's actually happening at the cellular level?
So when a patient first enters shock, the body's natural defense mechanism is to release massive amounts of endogenous vasopressin.
Right, that's a peptide hormone synthesized in the hypothalamus, right?
Exactly, and stored in the posterior pituitary. It dumps this hormone into the bloodstream to constrict the smooth muscle of the blood vessels.
Trying to maintain vital organ perfusion.
Right, but that reserve is not infinite.
Far from it.
In severe, prolonged septic shock, the autonomic stress is so relentless that the neurohypophyseal stores are just rapidly exhausted.
The well simply runs dry.
Yeah, patients develop a profound relative vasopressin deficiency. And at the same time, you have severe acidemia and this massive surge of nitric oxide in the bloodstream.
And those are actively uncoupling the alpha receptors from their G proteins, right?
Exactly. So the vessels are dilated by inflammatory mediators, the endogenous vasopressin is gone, and the alpha receptors are deaf to the norepinephrine you are infusing.
That sets up the fundamental premise of the trial perfectly.
It really does.
If the problem is that the endogenous vasopressin has run dry, the elegant obvious physiological answer is to just replace it.
Right. I mean, we replace thyroid hormone when it's low.
We replace insulin.
Exactly. Why not replace the missing vasopressin?
But let me push this back to you and to everyone listening. Why does a paper exploring that basic physiological concept from almost 2 decades ago still matter so much to you when you are standing at the bedside today?
Well, it matters today because the stakes haven't changed. Septic shock remains a relentless killer.
Yeah, historically carrying a mortality rate between 40 and 60% in these severe cohorts.
And the VAST trial didn't just test the efficacy of a synthetic hormone replacement, it forced the entire field of critical care to reevaluate our monolithic reliance on catecholamines.
It asked us to think about receptor fatigue, drug toxicity, and the timing of our interventions.
Which is huge. And that concept of timing brings us straight to the broader context, which Dr. Joseph Perillo captured so urgently in his editorial.
Right? He threw down a statistic that should stop any clinician in their tracks.
I remember reading it for the first time.
He noted that septic shock kills roughly 215,000 people a year in the United States.
And he makes a direct, unflinching comparison to acute myocardial infarction. The death tolls are remarkably similar.
That comparison is vital because it highlights a massive cognitive dissonance in modern medicine.
Oh, for sure. When you think about how our medical system responds to an acute myocardial infarction, it is a highly rehearsed, aggressive, and perfectly synchronized machine.
A patient arrives in the emergency department with chest pain, and what happens?
A 12-lead electrocardiogram is snapped within minutes.
And you see that ST segment elevation, and it triggers an immediate, overwhelming institutional response.
Right. The catheterization lab is activated, the interventional cardiologist is paged, and reperfusion therapy begins.
The pathway is beautifully binary and aggressively fast.
But here's the catch with that urgency. A heart attack gives you an ST elevation. It gives you a clear, flashing red light.
Sepsis lies to you.
It really does. It is insidious and vague.
You might have a patient on the floor with low-grade fever, their heart rate is creeping up into the 110s, the white count is elevated.
And the mean arterial pressure is just hovering around 62 or 63.
There is no single alarm bell. And because the presentation is messy, it breeds clinical hesitation.
We decide to wait for the lactate to result. We wait to see if the second liter of crystalloid does the trick. We wait for the central line to be placed.
And Perillo's editorial is screaming at us that this hesitation is lethal.
It is. Clinicians historically have not felt the same visceral panic regarding septic hypotension that they feel for an occluded coronary artery.
But the physiological reality is identical. Tissue is dying.
Exactly. The data from researchers like Kumar demonstrated that the duration of hypotension prior to effective antimicrobial therapy and cardiovascular support is the single strongest determinant of survival.
I love borrowing a concept from our trauma and cardiology colleagues here, the golden hour.
Oh, that's a great way to frame it.
If we apply that to sepsis, delaying support past that golden hour is the exact equivalent of staring at an FT elevation and deciding to go get a cup of coffee.
You are letting the microcirculation collapse.
Does that make sense for the trainees? The entire premise here is that if you are treating a heart attack with lightning speed, you must treat septic vasoplegia with that exact same ferocity.
That is the perfect framing. If survival drops precipitously for every hour, a patient remains in shock from roughly 80% survival in the first hour down to less than 50% by hour 6, we need tools that reliably and rapidly restore perfusion.
Right. If norepinephrine is failing due to receptor downregulation or causing deadly arrhythmias at high doses, we urgently need a viable alternative.
Which is exactly what the investigators of the VASST trial set out to provide.
Let's look at the mechanics of this trial because, from an operational standpoint, pulling this off in the early 2000s was a monumental achievement.
Oh, the logistics are wild.
This was a multi-center, randomized, double-blind trial involving 778 patients across tertiary care centers in Canada, Australia, and the United States.
And the inclusion criteria tell you exactly who we are dealing with.
Walk us through that.
So to be enrolled, patients had to be in fluid-unresponsive septic shock, and they had to be requiring a minimum of 5 micrograms per minute of norepinephrine, or its equivalent, for at least 6 consecutive hours.
That minimum threshold is a crucial detail. The investigators deliberately bypassed the early fluid-responsive phase of sepsis.
Exactly. They specifically targeted patients who were already heavily dependent on background vasopressors, whose vascular tone was already compromised enough to require continuous catecholamine support.
From there, the intervention was remarkably focused.
They randomized these patients to receive either low-dose vasopressin titrated between 0.01 and 0.03 units per minute, or a blinded infusion of norepinephrine titrated between 5 and 15 micrograms per minute.
And this blinded study drug was layered directly on top of whatever open-label background pressors a clinical team was already running to keep the patient alive.
Right.
I have to pause here because the methodology is just mind-bending. When you actually think about the logistics of this at the bedside, it sounds like a recipe for a massive medication error.
Oh, a total pharmacy nightmare.
How do you successfully double-blind two entirely different, highly potent, titrated pressor infusions in a chaotic intensive care unit without the bedside nurse or the attending physician knowing what they are dialing up?
It required an incredible partnership with the investigational pharmacies.
The pharmacists were the only ones holding the unblinding key, right?
Exactly. They prepared identical 250 milliliter intravenous fluid bags. If the patient was randomized to vasopressin, the bag contained 30 units of the hormone. If they were randomized to the control arm, the bag contained 15 milligrams of norepinephrine.
So the bedside nurse simply receives a bag labeled study drug.
Precisely. And the protocol dictated that they start the infusion of this mystery study drug at 5 milliliters per hour.
And if the blood pressure goal wasn't met,
They titrated it up by 2.5 milliliters per hour every 10 minutes, hitting a ceiling at 15 milliliters per hour.
got it. At that maximum rate, the patient was receiving either the full 0.03 units per minute of vasopressin or the 15 micrograms per minute of norepinephrine. But let's ground this in reality. How would you explain this to a nurse at 2 a.m.?
It's a lot to manage.
That nurse is managing a mechanically ventilated patient, juggling continuous renal replacement therapy. And now they have to manage this blinded study drug alongside their open-label pressors. How does that dance actually work to maintain a target mean arterial pressure of 65 to 75 millimeters of mercury?
The choreography of the protocol was very strict. First, you maximize the blended study drug up to its safe ceiling of 15 milliliters per hour.
Okay, so you push the mystery bag to the max first.
Right. If the patient's mean arterial pressure is still below 65, you leave the study drug at its max and you start aggressively dialing up your known open-label background pressors.
Your standard norepinephrine, your epinephrine, whatever you need to maintain perfusion.
Exactly.
Okay, that makes sense for the escalation phase. But what happens when the patient starts turning the corner?
This is where the design shines. As the vascular leak seals and the blood pressure improves, the protocol forced clinicians to taper the open-label background pressors completely off first.
Oh, wow.
Yeah, you do not touch the blinded study drug until the patient is completely weaned off all other pressor support.
That is the genius of the trial. By forcing the open-label drugs off first, they ensured that the study drug, whether it was the vasopressin or the supplemental norepinephrine, was doing the heavy lifting for the maximum possible duration.
It forced the primary physiological question to the surface. What happens when this specific intervention is the last drug standing?
Incredible. Let's do a quick recap to lock in the trial design before moving forward.
Good idea.
The investigators successfully randomized 778 critically ill patients, all of whom required at least 5 micrograms of norepinephrine per minute for 6 hours.
They added a blinded titratable infusion of either low-dose vasopressin or additional norepinephrine on top of standard care.
And the primary goal was to see if replacing that depleted vasopressin could significantly reduce mortality compared to just pushing more catecholamines.
Perfectly summarized.
With the methods clear, we need to look deeply at the baseline characteristics of these 778 patients, because who they were completely reframes how we must interpret the eventual result.
Oh, absolutely. The severity of illness here was staggering.
It really was. The average Apache 2 score at baseline was around 27.
We all know what a score that high implies about the imminent risk of death. These patients were in profound multi-organ failure.
Nearly 90% of them were in respiratory failure, requiring mechanical ventilation.
Over 67% had acute renal failure.
So this was not a cohort of patients with a mild urinary tract infection on a nasal cannula. These were deeply sick, physiologically fragile individuals.
They were sick, undoubtedly, but here is the massive revelation buried in the baseline hemodynamic tables.
Oh, I know exactly where you're going with this.
When you look at the mean arterial pressure of these patients at the exact moment of randomization, it was sitting at 72 to 73 millimeters of mercury.
Think about that for a second. If their blood pressure was already well above the target of 65, this was not a rescue trial for actively crashing patients.
That is a critical paradigm shift.
It really is.
When we hear vasopressin in septic shock, Many clinicians immediately think of salvage therapy.
They picture the patient whose blood pressure is 40/20, the lactate is 14, the pH is 6.9.
And the team is just throwing every ampule of medication they can find into the central line.
But that is not who is enrolled in VASST.
Because their blood pressure was already adequately maintained on background catecholamines at the time of randomization, this trial was fundamentally asking a different question.
Right. It was asking, if we interview now while they're still perfusing, can we use low-dose vasopressin as an adjunct to spare the body from the toxic arrhythmogenic effects of escalating norepinephrine doses?
It was a catecholamine-sparing trial, not a last-ditch salvage trial.
And returning to your 2 a.m. clinical scenario, that makes perfect sense. Picture that nurse at the bedside. The mean arterial pressure is 72, which looks great on the monitor.
The patient is perfusing their brain and kidneys.
But to keep that number in 72, the nurse is having to bump the norepinephrine up from 10 to 15 to 20 micrograms per minute over the course of the night.
The trajectory is highly alarming, even if the absolute number is currently safe.
That is the quintessential VAST patient. They haven't fallen off the cliff yet, but they are sprinting toward the edge.
But there is a glaring piece of context in the baseline data that we cannot ignore, especially given our earlier conversation about the golden hour.
The timing.
Yes. The average time from a patient meeting the diagnostic criteria for septic shock to actually receiving the blinded study drug infusion was roughly 12 hours.
12 hours. When you consider the microvascular destruction happening in profound sepsis, 12 hours is a physiological eternity.
It fundamentally contradicts the urgency Dr. Perillo was demanding.
If we know that survival drops precipitously in the first 6 hours of unreversed shock, what does a 12-hour delay do to the intervention?
It forces us to speculate heavily. If you wait 12 hours to replace the missing vasopressin, are you simply arriving too late to the fire?
By hour 12, the systemic inflammatory response syndrome has triggered widespread endothelial damage.
Capillary leak is severe. The glycocalyx is shredded.
The smooth muscle receptors are not just downregulated, the vascular architecture itself is structurally failing.
Exactly. It is entirely plausible that this massive delay in study drug initiation severely blunted the trial's ability to demonstrate a broad, overarching survival benefit.
So the board is completely set. We have 778 highly critical patients. Their blood pressures are currently stable, but only at the cost of significant catecholamine support.
And we are introducing our study drug, on average, 12 hours into their shock state.
The envelopes are unblinded. What were the primary results?
So the primary endpoint was 28-day mortality from any cause. When the dust settled, there was no significant difference between the two groups. The mortality rate was 35.4% for the patients receiving vasopressin and 39.3% for the patients receiving norepinephrine.
The p-value was 0.26.
Yeah. From a strict statistical standpoint for the primary outcome, the trial was a wash.
And if you look further out to the 90-day mortality, the curves didn't magically separate either, did they?
No, the 90-day mortality results mirrored the 28-day findings. It was 43.9% for the vasopressin group versus 49.6% to the norepinephrine group, yielding a p-value of 0.11.
Again, no statistically significant survival benefit for the overall cohort.
However, the hemodynamics, the actual physiological response to the drug, told a very different story than the mortality curves.
Right. The protocol ensured both groups maintained a similar mean arterial pressure, but how they achieved that pressure was radically different.
The vasopressin group demonstrated exactly what we hoped for biologically. Patients receiving the vasopressin infusion had significantly lower heart rates compared to the norepinephrine group.
And most importantly, their requirement for open-label background norepinephrine plummeted.
The drug acted as an incredibly potent catecholamine-sparing agent.
So the V1 receptors in the vascular smooth muscle were alive, well, and responding beautifully.
Yes. The vasopressin was successfully constricting the muscles, allowing the clinicians to rapidly back down the toxic doses of alpha agonists.
Hemodynamically, it was a resounding success.
Oh.
But this brings up the critical tension of the trial.
Exactly.
Because I have to look at this strictly from an evidence-based medicine perspective. The primary endpoint failed. We are taught that if a drug doesn't save lives or significantly improve meaningful morbidity, we shouldn't routinely use it just because it makes the numbers on the monitor look prettier.
Fair point.
If this is an overall negative mortality trial, why didn't the medical community just throw vasopressin in the trash in 2008? What's the bedside takeaway here? Why are we dedicating an entire deep dive to a failed intervention?
It is a totally valid challenge. We didn't discard vasopressin for two major reasons. The first is its safety profile, which we will unpack shortly. But the second, and perhaps the most debated aspect of this entire trial, was a massive, incredibly noisy signal found in a specific subgroup of patients.
The infamous subgroup analysis. Let's dig into this, but first, a quick reset.
Sure.
To summarize the primary result for everyone, adding low-dose vasopressin to standard care did not significantly reduce 28-day or 90-day mortality across the entire broad cohort of patients in septic shock, despite successfully lowering the need for concurrent norepinephrine.
That's the headline.
But then, the investigators cracked open their predefined stratifications.
Right. Before the trial even started, the researchers prospectively decided to stratify the patients based on the severity of their shock at baseline.
They divided the cohort into two camps.
Yes. Less severe shock, which they define as patients requiring between 5 and 14 micrograms of norepinephrine per minute at baseline.
And more severe shock, defined as patients requiring 15 micrograms per minute or more.
Exactly.
And when they looked at the more severe shock group, the sickest of the sick, what happened?
Nothing. The mortality rates in that severe subgroup were functionally identical. 44.0% for the vasopressin arm versus 42.5% for the norepinephrine arm.
Adding the hormone did absolutely nothing to alter the trajectory of their multi-organ failure.
But then they look at the less severe shock subgroup, the patients who are on lower doses of baseline pressors.
And here is where the data jumps off the page. In that less severe shock subgroup, the patients receiving vasopressin had a significantly lower 28-day mortality rate, 26.5%, compared to 35.7% in the norepinephrine group.
That is nearly a 10% absolute risk reduction in mortality. That is a massive number in critical care medicine.
But I have to throw the flag on the play here.
I knew you would.
We are rigorously taught in fellowship to be deeply, intensely skeptical of subgroup analyses in an overall negative trial.
Yeah.
It's the classic statistical trap.
It is.
If you slice a negative trial into enough pieces, you will eventually find a false positive with a p-value of 0.05 purely by random chance. Are we overcalling that subgroup, or is there a real clinical lesson there?
It is the most important question to ask about VASST. Statistically, Dr. Perillo and the trial authors were very clear. You cannot take a subgroup finding from a negative trial and declare it as definitive, incontrovertible clinical proof.
Right. It is strictly hypothesis generating. It tells you where to look next, not what to carve in stone.
Taking that a step further, though, the critical care community absolutely latched onto this finding. It heavily influenced international guidelines.
Why did we trust a hypothesis-generating signal so much?
Because of profound biological plausibility. We didn't just trust the math, we trusted the mechanism.
Let's go back to the rusted lock metaphor.
Yes. As septic shock progresses into its late severe stages, the environment in the microcirculation becomes incredibly hostile. The profound acidemia essentially rusts the alpha-1 receptor entirely.
The intense local production of nitric oxide causes irreversible vasodilation.
If you wait until a patient is in more severe shock, requiring massive escalating doses of catecholamines to achieve any tone, the vasopressin is simply arriving too late.
The vascular smooth muscle is too physically damaged and vasoplegic to respond effectively, even if you are providing a brand new hinge with the V1 receptor.
Exactly. The structural integrity of the vessel is gone.
But if you intervene during the less severe phase, when the patient is only requiring 5 to 14 micrograms of norepinephrine, the V1 receptors are still viable.
The smooth muscle can still contract. You can successfully restore vascular tone and preserve capillary perfusion before the irreversible late-stage damage occurs.
The subgroup finding makes perfect logical sense when you understand the timeline of vascular collapse.
So it's fundamentally about the window of opportunity. If you wait until the house is completely engulfed in flames, showing up with a different type of fire hose isn't going to unburn the structural beams.
You have to deploy the secondary hose while the fire is still manageable.
Precisely.
To summarize this crucial subgroup finding, while statistically it is only hypothesis generating, the strong signal that vasopressin improves survival in less severe shock aligned perfectly with our understanding of vascular physiology.
It screamed at us that earlier intervention with a second mechanism of action is superior to late salvage.
And that leads directly to the other major reason vasopressin wasn't abandoned: the safety data. We have to talk about the fear surrounding this drug prior to 2008.
Oh man, the ghost stories.
Right. If you are a trainee listening to this, you are probably well aware of the ghost stories regarding vasopressin. It is a wildly powerful non-adrenergic vasoconstrictor.
For decades, the nightmare scenario for any clinician hanging this drug was that it would clamp down the peripheral and splanchnic blood vessels so aggressively that it would cause severe ischemic damage.
Nobody wants to stabilize a mean arterial pressure, only to have the patient lose their fingers, toes, or bowel to ischemic necrosis a week later.
The fear of mesenteric ischemia was palpable. In the 1990s, when vasopressin was occasionally used at much higher uncalibrated doses for shock, we saw horrific ischemic complications.
But the VASST trial purposefully utilized a low physiologic replacement dose of 0.01 to 0.03 units per minute, and the safety data they published was incredibly reassuring.
What did the overall adverse event rates look like?
The overall rates of serious adverse events were nearly identical between the two groups, sitting right around 10% for both the vasopressin and the norepinephrine cohorts.
So it did not cause a massive spike in catastrophic ischemic events across the board.
But when you look closely at the flavor of those adverse events, there were some subtle, highly logical trends, weren't there?
Yes, the specific types of adverse events mapped perfectly to the mechanisms of the drugs. The norepinephrine group demonstrated a trend toward a higher rate of cardiac arrests,
2.1% versus 0.8% for the vasopressin group.
which makes total sense. Catecholamines are highly arrhythmogenic. When you are whimming a stressed ischemic myocardium with high doses of norepinephrine, you are drastically increasing myocardial oxygen demand and electrical excitability.
You are practically begging for ventricular tachycardia or fibrillation.
Conversely, the vasopressin group showed a trend toward a higher rate of digital ischemia.
2.0% versus 0.5% for the norepinephrine group.
So you have a slight increase in the risk to the fingers and toes with vasopressin, balanced against a slight decrease in the risk of stopping the heart entirely with norepinephrine.
In the grand scheme of an intensive care unit resuscitation, I know which complication I'm more willing to manage.
However, we have to highlight a massive, glaring caveat in the methods section regarding safety.
The cardiac exclusion.
Yes, the VASST researchers were not reckless. They deliberately and explicitly excluded patients with severe acute ischemic heart disease.
If a patient had New York Heart Association Class 3, or VI heart failure, or an unstable coronary syndrome, they were not allowed in the trial.
Why is that exclusion so critical for our listeners to understand?
Because you cannot take the reassuring safety data from this specific trial and blindly apply it to a patient with a failing left ventricle. Vasopressin is a pure vasoconstrictor. It does not have any inotropic properties to help the heart squeeze.
Right.
Therefore, it significantly increases left ventricular afterload, the resistance the heart has to pump against to eject blood into the aorta.
A healthy, hyperdynamic septic heart can easily push against that increased resistance to maintain blood pressure. But a failing ischemic heart might just hit that wall of resistance and simply give out, throwing the patient into cardiogenic shock on top of their septic shock.
Exactly. Dr. Perillo warned strongly in his editorial that if vasopressin had been given indiscriminately to patients with severe underlying heart disease in this trial, the investigators likely would have seen a devastating spike in cardiovascular adverse reactions and mortality in the vasopressin arm.
So the bedside takeaway on safety is heavily nuanced. Low-dose vasopressin, capped at 0.03 units per minute, was established as a reasonably safe intervention, but only when used judiciously in screened patients.
You have to respect the pharmacology of the drug, and you must understand your patient's baseline cardiac function before you hang it.
It is not a poison, but it is absolutely not a panacea you can just use blindly on every hypotensive patient.
That perfectly transitions us from the trial data directly to the daily practice on the wards. We've dissected the meticulous methods, we've reckoned with the overall negative mortality endpoint, we've explored the biologically sound subgroup signal, and we've contextualized the safety profile.
So let's bring it right to the bedside.
How did this paper actually change what people do on rounds? If I walk into an intensive care unit today, how is the ghost of VAST actively guiding the decisions of the fellow and the attending?
It completely dismantled the Hail Mary paradigm. Prior to 2008, vasopressin was largely viewed as a drug of absolute last resort.
You used it during the salvage phase.
The patient was already on maximum doses of norepinephrine, they were on epinephrine, they were on vasopressin at varying non-standardized doses, their pH was profoundly acidemic, and you were essentially out of options.
You hung the drug and crossed your fingers hoping for a miracle.
Right. It was an act of desperation when the primary strategy had already failed.
But VASST proved definitively that if you wait for the salvage phase, the drug does not work. The mortality in the severe shock group was identical. The tissue is already too far gone.
Where the drug showed its true promise and where it demonstrated profound catecholamine-sparing effects was earlier in the cascade of shock. It shifted the entire timeline of intervention. Today, clinicians reach for vasopressin much, much earlier.
Give me a specific clinical threshold.
When a patient is on, say, 10 or 15 micrograms of norepinephrine and their pressure is still marginal or requires frequent upward titration, we don't just blindly push the norepinephrine up to 30, 40, or 50 micrograms anymore.
We stop.
We recognize the escalating trajectory, and we add that steady, low dose of 0.03 units per minute of vasopressin early. We use it to cap the catecholamine toxicity before it spirals.
I love conceptualizing this using a mechanical analogy. Think of vascular tone as a heavy vault door that you need to keep closed to maintain blood pressure.
I like this.
Norepinephrine is a worker pushing on the left side of the door. If the pressure drops, your old strategy was just to yell at that one worker to push harder and harder. Eventually, that worker gets exhausted, their muscles fail, and the door swings open.
That is receptor downregulation and catecholamine toxicity perfectly described.
Vasopressin is simply a second worker pushing on the right side of the door. It uses an entirely different mechanism, the V1 receptors. By bringing in the second worker early, while the door is still manageable, you give the first worker a break.
You achieve the same goal, keeping the vault door closed, but you spare the body from the toxic arrhythmogenic effects of just pounding on those fatigued alpha receptors.
That is the true legacy of the trial. It redefined vasopressin from a final act of desperation to a calculated early adjunct. It taught us that multimodal receptor therapy is superior to monolithic catecholamine escalation.
This has been a phenomenal, sweeping breakdown of a dense topic.
Let's bring it all home for the listeners. We always like to close out PRISM rounds by distilling the complexity into crisp, actionable takeaways that you can use on your next shift. Let's deliver our 5 bedside pearls from the VASST trial and Dr. Perillo's editorial.
Pearl number 1. VASST was fundamentally an overall negative mortality trial. Adding low-dose vasopressin did not significantly reduce 28-day or 90-day mortality across the entire broad group of septic shock patients compared to using norepinephrine alone. We must acknowledge the strict statistical reality of the primary endpoint.
Pearl number 2. Low-dose vasopressin, specifically capped at 0.03 units per minute, appeared reasonably safe. The rates of serious adverse events were similar to norepinephrine, largely dispensing with the myth that it causes rampant mesenteric ischemia at physiologic doses.
However, this safety assumes you are carefully screening your patients and avoiding its use in those with severe ischemic heart disease or heart failure, where increased afterload could be disastrous.
Pearl number 3. The less severe shock signal was statistically hypothesis-generating, but clinically highly influential. Patients on lower doses of norepinephrine at baseline between 5 and 14 micrograms per minute seemed to derive a survival benefit.
This biological plausibility changed our practice, moving vasopressin from a late-stage rescue therapy to an early catecholamine-sparing adjunct.
Pearl number 4. Timing matters intensely. In the trial, the study drug was started an average of 12 hours after meeting shock criteria, which likely blunted the potential benefits. In sepsis, delaying cardiovascular support or effective antimicrobials allows microvascular destruction to proceed unchecked, drastically reducing the odds of survival.
And pearl number 5, drawing directly from Dr. Perillo's plea to the medical community, septic shock deserves the exact same visceral urgency as an acute myocardial infarction.
Do not let the ambiguous, insidious presentation of sepsis lull you into a false sense of security or clinical hesitation. Respect the golden hour. Time is tissue, whether the insult is in the coronary arteries or the systemic microcirculation.
Those pearls perfectly encapsulate the journey of this data, from the rigid columns of a journal page straight to the messy reality of the intensive care unit.
But before we sign off, I want to leave you with a final provocative thought to mull over as you head into your next shift.
I'm ready for it.
We noted early on that the baseline vasopressin levels in these profoundly shocked patients were deeply depleted, dropping as low as 3.2 picomoles per liter.
Right.
Yet right now, in 2026, we still dose vasopressin completely blindly. We hang a flat 0.03 units per minute for everyone, regardless of their actual circulating hormone levels. But if we know the baseline deficiency is the core physiological problem, are we rapidly approaching a future where we don't just guess who needs vasopressin?
That's interesting.
Imagine a critical care landscape where we actually measure a patient's peptide levels in real time at the bedside, using that data to personalize and titrate their pressor therapy. Picture a monitor that doesn't just show you the blood pressure, but actually alarms to tell you exactly when the endogenous vasopressin reserve runs dry, cueing you to replace it at the precise biological moment it is needed.
That would be the ultimate realization of precision medicine in the intensive care unit. Moving from rigid protocols to dynamic, personalized physiological replacement, it is an incredibly fascinating frontier.
It really is, and it's the kind of innovation that trials like VASST pave the way for by forcing us to ask better questions. Well, that brings us to the end of our deep dives into the VASST trial.
We hope this comprehensive look at the physiology, the data, and the bedside realities gives you a much clearer, more confident lens through which to view your pressor choices.
Thank you for joining PRISM Rounds. Keep questioning the algorithms, keep learning the mechanisms, and we will see you on the wards.
Thank you for spending your time with Prism Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve, pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.